Welcome back, everyone. Today on Health Code Blueprint, we're diving into the world of unspecified diagnosis coding, and how something that seems small can have a huge impact on coding integrity, reimbursement, and even patient access to care. We're going to walk through two real-world scenarios, compare the documentation to the final coded diagnoses, and talk about what went right, what went wrong, and how we can prevent these issues moving forward. Before we begin, here's a quick disclosure. This presentation is for educational purposes only. It does not constitute legal, compliance, or billing advice. Always follow official ICD 10-CM guidelines, organizational policies, and regulatory requirements. Let's start with the core problem. Unspecified diagnosis codes may look harmless, but they're actually one of the biggest drivers of reimbursement delays and claim denials. When the documentation is vague, the codes end up vague, and that creates a disconnect between the care that was provided and the justification the payer needs to approve it. But here's the twist. Sometimes the documentation is specific, but the final diagnosis coding doesn't capture all those details. And when that happens, we run into the exact same issues. This is where the cycle begins. Unspecified codes lead to denials, they delay patient services, and they ultimately block cash flow. It's a small coding choice with very real financial consequences. Now, this isn't just a fee-for-service issue or a risk adjustment issue. Unspecified coding affects every payment model. In fee-for-service, specificity is what proves medical necessity. In risk-adjusted care, specificity is what captures the patient's true disease burden. Either way, if the code is vague, the reimbursement will be too. Let's jump into our first case. We have a 68-year-old female with type 2 diabetes, presenting for follow-up of a chronic, non-healing diabetic foot ulcer. A selective sharp debridement was performed, CPT 97,597. Everything in the documentation points to a very specific clinical picture. Additional documentation from the provider gives us everything we need. The exact ulcer location, the measurements, the appearance, the slew, the fibrin, all of it. The procedure notes clearly outline the debridement itself, the depth, and the final result. And the assessment ties the whole picture together by linking the diabetes to the right big toe ulcer. So the documentation is solid. Now let's take a look at what happened once this moved into coding. Here's where things fell apart. The claim was submitted with E11.9, diabetes without complications in T14.8 unspecified injury of an unspecified body region. And as you can imagine, the claim was denied. The codes didn't match the clinical reality, and the payer couldn't justify the debridement. On this slide, you can see the correct coding already laid out. The documentation fully supports diabetes with a foot ulcer, the specific ulcer site and severity, and long-term insulin use. These codes establish medical necessity and accurately capture the patient's risk. This is exactly what should have been submitted the first time. Now let's move into our second scenario. Here we have a 42-year-old male being evaluated for bariatric surgery. The provider documents the patient's weight, height, and a BMI of 42.3. The requested procedure is a laparoscopic sleeve gastrectomy. The provider goes even further and documents the clinical term, morbid obese male, and includes a plan for referral to bariatric surgery. So again, the documentation is clear, specific, and supports a very precise diagnosis. Despite all that detail, the referral was submitted with a single unspecified code, E66.9, obesity, unspecified. And just like in the first case, the payer denied the request. E66.9 doesn't meet medical necessity criteria for bariatric surgery, and it doesn't map to an HCC, so the patient's risk wasn't captured either. On this slide, you'll see the correct coding based on the documentation. The provider clearly supported morbid obesity and a BMI over 40, which aligns with the codes shown here. These codes meet payer criteria and accurately reflect the patient's severity. These two cases highlight a bigger issue, the gap between what's documented and what's coded. To close that gap, we need a system that consistently translates the full clinical picture into the most specific codes possible. That's where our key principles come in. The three pillars of documentation and coding excellence are simple but powerful: document completely, code specifically, and educate continuously. When these three elements work together, denials drop, risk scores improve, and the clinical story becomes crystal clear. Here's how we make it real. First, proactive provider education, showing clinicians exactly how documentation impacts reimbursement and risk adjustment. Second, strong query practices, clarifying documentation before the claim goes out the door. These two steps alone can prevent most of the issues we saw in both case files. And finally, documentation isn't just a coding requirement, it's the foundation of patient care and financial integrity. Every detail in the record tells the patient's story and supports the resources needed for their care. Specificity protects the patient, supports the provider, and strengthens the entire revenue cycle. Thanks for joining me today on Health Code Blueprint. I'll see you in the next session.